Meeta is a well-known gynecologist and obstetrician at the Tanveer Hospital in Hyderabad. She has more than 22 years of experience in these fields, and she has been the past president of the Indian Menopause Society. She's a very active member of the Foxy and several other societies. She's also very active at the with the International Menopause Society also, and so I have great pleasure in inviting her. She has been the editor-in-chief of the Journal of Midlife Health, and so I invite her to speak on menopause. She's going to speak about various aspects of menopause and probably focus on hormonal therapy. And yeah,
Surprise.
that's been her interest, and so let's see her what she's going to speak today about menopause.
Thank you, Dr. Rakesh and respected colleagues on the dais. And I would like to thank Dr. Sudhakar, Dr. Sham, Dr. Rakesh, Idea Clinics for inviting me on this very interesting topic, menopause. So menopause is, like we should make it like a radiant Indian summer. And there's always been a debate all the time, whether it's a normal developmental experience or is it some pathology which, you're hunting for a magic cure. So it's a debate between the two. But I think nature is guided best when we let it go and we, help it out. You shouldn't interfere when there is no need to interfere, which is 90% of the time. It's only 10% of the women who need attention. And so I have two colleagues of mine who had different experiences. So 90% of them fall in that one experience where they don't need any help except for, all the regular screen, which every one of us need now with the environmental pressures and the social pressures that we have. But 10% of them need attention. So how do we go about it? So the discussions are a little bit on facts and statistics, challenges and strengths that we have in India. How to set up a menopause clinic is what I thought, going back to the basic and implementing that knowledge. So the vision is, from my side, it's always been from the past 15 years, we should have menopause clinics just like antenatal clinics. And a midlife woman should not be passed off like an attender of the pregnant woman or of the adolescent girl or something like that. She has to be looked at as an individual. And all the more the need is increasing because the average lifespan of a woman in India is increasing from 60s to 70s now, 72, and it's going to increase further in the next couple of years. So we have more number of midlife women to deal with in the next few years. So all the youngsters have to start taking an interest in midlife and not just laparoscopy and, the infertility, which is much more alluring. So longevity versus disability. So none of us would like to be disabled. And as you're growing older, it is a quality of life which is very important. So metabolic syndrome at perimenopause in India is 22%, rising to 32% at postmenopause. So that is what is happening during the menopause transition. That means from the perimenopause to the menopause, there are a lot of changes, metabolic changes which are happening. So it's not just the vasomotor symptoms you're worried about. We are worried about so many other things that happen which will present at a later stage. So 30% of the Asian Indian adolescent with normal BMI and waist circumference are hyperinsulinemia. I think that was a wonderful talk, very simply put, with excellent examples by the previous speaker, and I think that this is one of the facts which come out of that. So Indians, definitely all of us know that higher percentage of fat, especially the abdominal obesity. So it's not just the BMI that we talk about it. So lean PCOs who have this abdominal obesity are still going to be that group which need that cardiovascular metabolic changes which are going to happen in the old age. And so it's not just the myocardial problem. Type 2 diabetes, we know, happens a decade earlier compared to the Western counterparts. 25 years back, 70% of the breast cancer patients were above 50 years of age in India, and probably because the obesity was not so bad and the physical activity and exercise were far better. But today, almost 48% of patients are below 50 years, and it's surprising that we have breast cancers even 30 years, 35 years old. So we are getting them at much younger age. So breast cancers in the young are hormone positive in 48% of the women. And apart from that, endometrial cancers, which would never get before menopause, we find them before menopause now. because of the PCOs and the the changes in the atmosphere. And also this is a well-known fact that osteoporotic fractures occur 10 to 20 years earlier, and but luckily, though the diagnosis is more, the number of fractures are a little lesser. So I don't know, but surprisingly, even we are bad with the muscle health. So in spite of that, there is something which is helping us. Probably our femur necks are better than the spine. Something is not doesn't fit in that well. But then 20% of our postmenopausal women also have the low muscle mass. So, and trends in cancer, like I've already alluded, that cancer cervix is lower, breast is increasing, uterus is increasing. So what are the medical challenges that we have in India which are different from the rest of the world? One is earlier median age of menopause, and all of us are aware that whether it is a POI or whether it is early menopause, the minute we say menopause is happening, there are a lot of changes happening, metabolic changes happening. So that is actually predisposing, setting a stage for metabolic disorders and osteoporosis. Thyroid diseases also again start happening then, just like in the adolescent period. So we need to, in India, 46.7 is the average age at menopause, hospital-based studies. We still need to have population-based studies for that. So we need to redefine what is premature and delayed menopause in India. Early onset of declining fecundity. We know that after the age of 30, the ovarian reserve starts falling in India compared to the 35 in the West. So there was a beautiful study which was done in the Spaniards and the Indian, the same group. And they found that the ovarian reserve and infertility treatment, the Indians did very badly compared to the Spaniards because the ovarian reserve was low. So why is it? It could be, transgenerational. It couldn't have happened any time. Maybe, in utero problems happening over generations, and that is why we are where we are now. So it is either dietary excesses or deficiencies in India. Deficiency of calcium, vitamin D, B12, folic acid. I'm sure all of you are finding this all the time. And on the other hand, we have to deal with the overtreatment that is happening, excess of vitamin D levels that we find now. So dominance of the non-vasomotor symptoms with us, widespread use of complementary and alternative medicines which are not standardized. So these are the medical challenges that we face in a menopause clinic. But then we also have our strengths. I think I removed that slide, but yeah, I have it. So calcium intake, studies done by the good group of endocrinologists from India have shown that an Indian average woman doesn't take more than 250 to 300 milligrams of calcium. Do you think that's enough? Absolutely not. And it's 300 to 400 maximum in the urban areas. So it's really not. It's really below the average standard that we should have. So what are the strengths? I think the best strength that we have is the faith. The faith and the traditional mindset, the culture, and we are a happy lot. We are not, so depressed like in the Western countries, but of course, Westernization is causing a change. The comfort and the cushioning of our traditional family has actually made a lot of difference into our mind process. Our diet and lifestyle is definitely far better because when you look at the Caucasians, it's all the stored food and the packed food that they have, whereas we still have the pleasure of having the fresh food every time. We have the pleasure of getting the fresh fruit and vegetables. And our lifestyle was much better earlier. So the faith and spiritualism, and menopause is accepted as a natural part of life, God's will. So earlier we were never worried about the wrinkles. We used to think the stoppage of periods was welcome because you're given a senior state in your family, you're better off. So this was my strength. So we have to work on the strength. So I always believe that working with what you have, where you are, and not with what you wish for is the principle that each of us clinicians should follow in our practice. So wherever you're in the urban, rural, any setting, we can do best for our patient with whatever we have. And this is the menopause book that we have from the Indian Menopause Society. And very important as to why should we have a menopause clinic like your diabetic clinic or an antenatal clinic is to offer a comprehensive, friendly services where you're looking at this midlife woman in totality. And that is why we should be having these specialized women menopause clinics all over India. And I think this year there has been a great thrust on it, and we have already started a couple of them, many of them in India, and we are already also talking to government hospitals where they can start menopause clinics. So the basic requirement is a core team. Core team, of course, will start with a gynecologist, but endocrinologist also can start it as long as they have somebody who could, do an internal examination and a pap smear. I think that's the only place where there will be a little difference. A nurse, a receptionist, second team of visiting consultants. So, the basic equipment that we need, then we have two levels of care. One is the primary care unit and multidisciplinary care unit. So anybody can start a primary care unit. It's just like a general physician's clinic. But then for a more advanced work, you definitely need to have multidisciplinary consultants, because after the age of 40, we know we have so many problems which are coming in, which come in, and like the PCOS, you need to have a multidisciplinary approach for a level of care. So, and documentation becomes very, very important. So a menopause performer, just like an antenatal card that we have for 9 months, but this is like for a lifelong. So you see them once in 6 months, then once annually, but then that card should be there. And like lot is being talked about metabolic disorders which are picked up during pregnancy, picked up with the PCOS, annual follow-ups. So when the annual follow-ups, you're doing the annual follow-ups, but if you're not documenting them, what's the point? So documentation is very important. So I said, forgive me if I'm going back to the basics, but I think these basics are very important, especially for the younger generation. So when a menopause specialist role and approach is, it's not just about menopause. You also have to look the aging aspect in that woman. So you stage the menopause, just like how we stage labor, we need to stage menopause as to which stage she is falling in, the perimenopause, the menopause transition, early postmenopause, late postmenopause. So when you're staging them in your mind, you know what you should be asking the questions, what are the tests to be done, and what are the problems that you may pick up at this particular point of her life. So then you divide them between symptomatic and asymptomatic. That is 90% no symptoms, 10% may have the vasomotor and the non-vasomotor symptoms. Then you do the risk assessment for disease, and you of course, first and foremost is the preventive health, and then is the treatment. So this is how, in a nutshell, you do it. I like this particular picture of mine because very simple tools. You just need a measuring tape, you need a BMI chart, you need an OSTA chart, you need a cardiovascular risk assessment chart, and you need probably, for the Gale model, your phone which you can do, your performer, and a simple urinary strip. We use it to check the vaginal pH. So that's a very simple technique that we use. So these are the simple tools for a primary care for a physician, and I think any physician can do it, need not necessarily be a gynecologist. So this is how we do it. And if you have the DEXA and the mammogram, that adds value to whatever you're doing. Pap smear and HPV is very important. Even the endocrinologist should start telling your women, please get your HPV done at least once in 10 years, and that's enough. 3 times, it's enough. So, excuse me. I've been having a bad throat. So the management is, the minute a woman walks into your clinic, you just, in your mind, go through the history, divide them into 2 groups. One is women without menopausal symptoms. Then you also subdivide them, presence or absence of comorbidities. Women with menopausal symptoms, presence or absence of comorbidities. And why do you need to do that? You simply need to do that because you want to decide the plan of management. So it's very simple when you divide them like that. You know which women you should be actually having a co-consultant, cross-consultation, where you have to send. Second is when to give MHT, when not to give MHT. If a woman is symptomatic, to give an MHT, to decide when to give an MHT, whether she is free from comorbidities or she has comorbidities. What are the comorbidities she have, and when can you give and when you should not be given. So these are the reasons why it's very, very important to group every woman who walks into your clinic, whether she is symptomatic, asymptomatic, with comorbidities, without comorbidities. And sometimes it's latent disease. So, that whole spectrum will come. Those with overt disease that you're picking up, or they come saying we are on those treatment, or you pick them up just by checking the blood pressure or some simple tests, and those who are in the latent phase, borderline phase. So these are all the comorbid situations where there are some women who are healthy, the rare kind. The rare ones after 40 who don't have any problems are really rare. So first staging, like I said, you must ask this question, when was your last period? Less than 3 months ago, regular bleeding, she is in the pre-menopause. Less than 12 months ago, irregular bleeding, 3 months amenorrhea, then she is getting into that late menopause transition. More than 12 months is when you say she is natural menopause. So staging of menopause is very, very important. You know exactly what to do, when to do, by dividing them into stages, because you know these are the disorders which surface in different part of your life. That is, in the menopause transition, there's a redistribution of fat. We know that from gynecoid to an android kind of a picture, and the vasomotor symptoms, the non-vasomotor symptoms come in during that menopause transition phase, and an unintended pregnancy is a big problem at that particular time. AUBs are very common, hyperestrogenic state, and low progesterone levels happen at that time. Later on, 5 years down menopause, you have the genitourinary syndrome, which becomes very important, and skin atrophy, nail changes, hair changes, hirsutism, frontal baldness, all of them start appearing. And later on, of course, after the age of 60 years, you have all the NICDs which present themselves at that time. But then they give you enough time. That means all the ones which are presenting at 60, I've actually started off 10 years earlier. It's for you to pick them up at that time. So preventive health becomes very important. So the issues in a symptomatic woman are skeletal-muscular, vasomotor, genitourinary, sexual, fat deposition, skin, eye, everything. So just like a PCO, a woman needs all of them even at midlife. So risk models are very important. So risk assessment at menopause transition becomes very important. I don't even have to talk about what is risk model to this audience, So I'm just going to talk about the risk models which we promote at menopause transition. First is the menopause rating scale for vasomotor symptoms. It's a 10-point scale where you write from 0 to 5, and then mild, moderate, severe. So this becomes very important for you to understand whether this woman needs hormone therapy. And then, for her also, if it's very severe, moderate to severe are the only ones who needs hormone therapy. Mild to moderate, you need not even go for hormone therapy. So when you scale it, when you have that scale for each woman who has got symptoms, and then you give them the treatment, they come back with you and say, our symptoms have reduced from severe to moderate. It's a pleasure for you and as well as the woman. Breast is right now, we don't have anything in India on our population, so GAIL is what we are promoting. CVD risk assessment is the WHO CRD, simple. There are other ones which you can use, but this is a simple one which even a paramedical can use. OSTA is again something which even a paramedical use, even the muscle health SARCF, genitourinary vaginal pH. So if Dr. Rakesh, if I have time, then I'm going to, so vasomotor symptoms, these are the 11 points that you have, and actually it comes in a beautiful picture where you have all these on one side and you have the date, the visits in columns, and you can enter over a period of 10 visits, and then you divide them from none to severe, and that is one risk assessment that you're doing. Breast is the risk assessment online model. So once you enter a few data, very simple questions, which you can ask your woman to enter it herself and come to you before she comes to you. And then that gives you a number. Less than 1.67 is low risk for breast cancer over a period of lifetime, and over a period of next 5 years to lifetime. So it gives both. Moderate is between 1.6 to 5, more than 5. So when you're doing this risk assessment, this also helps you when you're again deciding to give your hormone therapy. So when you're giving your hormone therapy, if she is falling into a high risk group, probably we will not be giving the hormone therapy. You're going to talk to her. But if she's in the low and moderate group, it's more comfortable for your own self when you do the risk assessment before you give the hormone therapy. And we know that compared to MHT, there are so many other risk factors which are worse when in relation to breast cancer. Obesity is 24 more cases if the BMI is more than 30, compared to MHT, which is maybe about 5 more cases. So there are so many other factors which cause breast cancer when you're looking only with the estrogen progesterone combination. In fact, when you're giving estrogen alone therapy, there are 8 less cases of breast cancer. So CVD risk prediction charts, we have the WHO ISO, which is very, very simple, but some of our Indian studies, they have quoted the British third, JBS 3, I think, which actually fared better than this, because this has got very simple things that we are adding on. So it underestimates the risk, whereas if you're using the JRBS 3, you actually estimate very well, and it's really not very difficult to do. But we are promoting this for a simple reason, that it can be done all over India by anybody, where you have these simple charts and you plot the age, the BP, diabetic, non-diabetic, smoker, non-smoker. I think you just have about 6 of them, and then you can chart them as mild, moderate, and severe. So I'm not going to go into the details, because I know all of you must be very good with all of these. So then you assess it. And even if they are high risk, then you don't give the MHT. So it's not for primary or secondary prevention, we know, but primary prevention, there is still a window where we feel that yes, it can work. Whereas low risk for CVD, moderate risk for CVD, we can give MHT. Moderate risk, we are going in for the transdermal MHT. So we always also assess the baseline for venous thromboembolism before you plan for MHT. So high risk, the history is there, you avoid MHT. Normal and low risk, transdermal or tibolone. Varicose veins, again, transdermal is preferred. But mind you, we used to say that once a woman has gone through pregnancy, then that's a clear chit that she will probably not develop problem, embolism or DVT with the pills. But then with so many other cofactors which happen, the dehydration, the obesity which they develop over a period of years, you have to be careful. Skeletal-muscular health, OSTA, is something which is, you just take the age and the weight and you plot the graph. And if you have the pleasure of the Frax and the DEXA, of course, that is the best thing to do. Though we don't have the Indian one, we follow the Singaporean one. We still don't completely go by it. So it's only the risk factors put together with this Frax that you plan the management. So Frax and OSTA is done only for screening. That is, once osteoporosis is diagnosed, you know you have to treat. But low bone mass, you don't know whether to treat or not to treat. So those are the cases where this screening modalities and Frax is going to help you take a decision whether to treat or not to treat. And assessment for sarcopenia, simple. If the patient is able to walk in, sit down, get up from the chair, you don't have to do anything, no risk assessment. But only if she's not, she takes support when she's getting up. Then you do the SARC-F questionnaire and then you go on further and confirm by DEXA and go ahead with some more tests to understand the muscle health. So the indications for DEXA, I think this I would give credit to Dr. Rakesh. I don't know whether he remembers it, but you know, we had a closed door meeting of the few group when we made the guidelines, the first guideline in 2012. And we were wondering what to do with the indications for DEXA, because the NOF and the IF says all the DEXA we should start doing only after the age of 65. And at that time, in 2012, the average age a woman could live was 65. So then we thought, what is the point in doing at 65? So actually Rakesh came up with this. He drew everything on a piece of paper and he showed us. He said, I think this would be a better idea, and all of us really liked it because it made a lot of sense and we had evidence to back it up. So all postmenopausal women, more than 5 years of menopause, postmenopausal women, less than 5 years of menopause with risk factors, women in menopause transition with secondary causes, radiological evidence of osteopenia and presence of vertebral compression fractures, all of them need to go for DEXA. And of course, apart from that, nowadays there's a lot of talk about the visceral fat, the muscle health, which you can pick up from the DEXA, which gives you a good amount of total overall health of the woman, because we know fractures are not only because of low bone mass or osteoporosis. Muscle health plays a very important role and we have to know about it. So once you have all these risk factors, this is what we advocate in a menopause clinic. You just put it down very nicely in a small chart, all the risk assessment over 5 years, lifetime, and finally the risk status for each organ of the body. And then you take a call as to how you're going to manage this woman. And it changes every year when she comes to you. Genitourinary syndrome, very simple. Like I said, the pH. pH has to be around 4.5. Anything more than that, you have to treat it. And I tell you, this is one of the simplest treatment with the best dividends. No contraindication for vaginal hormone therapy. Even except for breast cancer, even there's not a contraindication. You can give estriol, which is low, this thing, when you discuss with the patient and discuss with her consultant, and you can still give it. So management plan is very simple. No symptoms for all of them. It always starts with the preventive care, MHT when the symptoms are there, and treat the comorbidities. So a liaison between us, between the gynecologist, between the endocrinologist primarily, or the orthopedicians, or the dermatologist, or the cardiologist is very, very important. Never forget about immunization. Last but not the least, I put it in the end, but this becomes so adult immunization, after 50 immunization with comorbidities, and pneumonia for everybody after 65. I think simple rules. COVID is another one which has come in now, which we need to advocate. So I think immunization is something which we need to talk about. So in this one study, Balin and Wang, called Midlife Women, a critical window of opportunity for prevention. We keep hearing about this window of opportunity. It was termed by these two gentlemen, and I think it becomes very, very important that midlife is an important opportunity for all of us to take care. So, this is a tagline of actually, when I was the president, this is what I had introduced. And now this has been taken up as a tagline of Indian Menopause Society: fit at 40, strong at 60, independent at 80. So somebody asked, now people are living up to 80. So I said, okay, sophisticated at 100, so we may add that now. Thank you so much.
Thank you, madam, for the comprehensive overview of menopause, which you covered in the short time. So we'll have question answers for this session. If any questions are there, they are welcome. Yeah, Dr. Sham.
So all of you are professional level. So coming to PCOS, teenage PCOS, lean PCOS, what lifestyle changes do we advocate? How useful is lifestyle in patients with lean PCOS?
So the lifestyle changes, whether it is lean PCOS or obese PCOS, lifestyle changes matter. As far as the phenotype is concerned, there is a difference between lean and obese. So the lean PCOS are more oligoanovulatory and they have less hyperandrogenism. And lifestyle changes matter in both. Yeah, please, ma'am, please.
No, no, I mean, from my little experience of PCOS that we deal with, lean PCOs also need a similar kind of management like obese PCO, whereas the visceral obesity is concerned. Maybe it's, the general obesity that you're talking about, maybe they need more aggressive management. But I think the dietary control, because even if they're lean PCOs, because we are doing the body composition for most of these lean PCOs, and none of the lean PCOs have a normal visceral fat. All of them will have abnormal visceral fat. So finally, the abdominal obesity is there. So, the lifestyle changes would be the same. But in an obese person, for the neck problem and other things, it would be more aggressive. Yeah, and I just wanted to comment on that menarche, the first question, when you said, would you agree that whether this is a case of PCO? So it was like not a yes, not a no. It was like, that kind. So probably nowadays we're using this new terminology in my practice where we say PCO in evolution. Because rightly you said, there could be other causes of hyperandrogenism and, which you need to give 2 to 3 years of time before you label them as a PCO, because PCO is a lifelong kind of a label for them. So we probably would not call them, but we could use the term PCO in evolution.
Yeah, that's nice observation, and also I think as you have put it that they are not obese, but they have got sarcopenic obesity. You can say that they are lean and still have obesity, so they still require the lifestyle changes. Um, yeah, any questions from the audience? Any other questions? There's somebody. Yeah, please. There's one question at the back. Yeah, you have a mic with you? Can you pass a mic?
Ma'am, for you, with PCOS, you mentioned metformin as a treatment for dermatological manifestations. How is it effective, ma'am, and what's the role in other complications associated with PCOS?
Role of metformin in PCOS is number one, if there is a glucose intolerance. And number two, people were using PCOS, metformin along with clomiphene for ovulation induction to decrease the ovarian hyperstimulation syndrome. And number three, metformin helps in restoring the oligoanovulation in PCOS. Metformin is, though theoretically it reduces the hyperandrogenism, practically it is not helpful for a woman with hirsutism. It is not helpful.
Could I ask you a question about osteoporosis? How often do you, I mean, given your interest in osteoporosis, how often do you find, what is the prevalence of osteoporosis in postmenopausal women?
Yeah, so I think the low bone mass is what I see in my practice because most of them come during the menopause transition for us. And it's almost 40 to 50% of low bone mass that we see. Osteoporosis, yes, about 20% above the age of 30 years, above the age of 55, 60. Even at 55 and 60, we find osteoporosis. So according to the books, 80% by the time they are 80, low bone mass. Osteoporosis may be about 30%. Am I right, Rakesh? The books, what the
Thank
books
you. Yeah,
say.
yeah.
And something like that we find even in our practice. But low bone mass is definitely there. But what is worrying us along with the low bone mass, the sarcopenia is also quite prevalent. And we find sarcopenia, the muscle strength is low even in the younger women. But all the PCOS have good muscle.
So we tend to have
We
a,
are doing the body compositions for all the PCOs. You know, that's how we picked up the visceral obesity in all of them. And we find that all of them have good muscle, probably because of the hyperandrogenic state.
yeah, so that's a interesting.